Listen up.
All right, team, listen close. Nephritic Syndrome is an inflamed filter war where blood is actively leaking into the urine.
The triad you absolutely have to know: hematuria, hypertension, and azotemia. And that's a buildup of nitrogen waste products right in the blood.
Your key signs? Look for that classic Coca-Cola colored urine and red blood cell casts, non-negotiable.
Post-Streptococcal Glomerular Nephropathy, PSGN. You're thinking children, you're thinking low C3, and you're thinking subepithelial humps 2 weeks after a sore throat.
IgA Nephropathy? That's Berger's disease. Hematuria happens just days after an infection. Much faster.
And Alport, it's all about genetic collagen 4 defects with deafness and a basket weave biopsy. Know the blood, check the timing, save the nephron.
Let's go.
Silence? Before we proceed, a crucial point of order: our mandatory international medical disclaimer. This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
Okay, Sarah. In our last deep dive, we saw the leaky filter of nephrotic syndrome. Now, this filter is inflamed. We've got neutrophils invading the glomerulus.
So, walk us through it. Why does this inflammation lead to hypertension, even if the protein loss is less than 3.5 grams?
It's because the inflammation physically blocks the capillary lumens, Dr. Collins. This causes the GFR to just plummet, which triggers the renin-angiotensin system and causes massive salt and water retention. So that volume overload is exactly what drives the blood pressure up. And when we look at the urine, we see those RBC casts. That is the forensic proof, the smoking gun, that the bleeding is coming from the glomerulus, not from the bladder or the ureter.
Precisely. The molded blood. Excellent. Now let's tackle the timing trap. How do we distinguish IgA nephropathy from PSGN on the wards? It's all in the latency. IgA nephropathy is synpharyngitic. It happens within 1 to 3 days. But post-streptococcal GN is postpharyngitic, usually 1 to 3 weeks later. Plus, in PSGN, C3 levels are totally crashed, while in IgA, complements are usually normal.
Outstanding. And everyone watching, make sure you check the resources linked below for the latest biopsy criteria. Sarah, what about Alport Syndrome? This isn't just a kidney problem, is it?
No, it is a type 4 collagen disaster. This collagen is a key component in the kidney, the ear, and the eye. So the patient presents with that classic, unforgettable triad: can't see, can't hear, can't pee.
And on electron microscopy, you'll see the classic basket weave appearance. It's pathognomonic. It happens because the basement membrane is thinning and splitting apart. Spot on! So remember, everyone, IgA is fast, PSGN is slow, Alport is familial.
All right, here's our question of the day. Have you ever seen Coca-Cola colored urine in the clinic? I mean, it is a really striking finding that, usually terrifies the patient. Tell us the case history in the comments below. We'd love to hear it. Sarah, time to lock in the inflamed filter. You ready? Ready.
The triad: blood, pressure, azotemia. IG. Days after. PSGN.
Weeks after.
Alport.
Basket weave deafness. RBC casts.
Is the glomerulus.
Step 2 complete. The key takeaway is this: if you see blood in the urine, you have to check the timing. And of course, review the resources.
Mastered. But what happens when the filter collapses not over weeks, but in days, with massive crescents? Well, you're going to want to subscribe and join us for our next explainer on RPGN, the crescentic crisis. We'll see you there.